Hello, everyone. I think we're going to start our second pediatric retina session today. It's me, Ahmed Barki. I'm a VR surgeon at Vishali Medical City, and it's a pleasure for me to have Dr. Madhav Rao is going to moderate the session with me and with a lot of eminent speakers. And thank Dr. Muhammad Al-Amri for his kind invitation and for the excellent arrangement of the meeting. So without waiting too much time, I'm going to present our first speaker, Dr. Faisal Fayyad. I know everyone knows him. You know, no more introduction. He's a senior VR surgeon in Jordania Hospital at Amman, Jordan. Dr. Faisal will give us a talk about the giant retinal tear in children. Dr. Faisal, please.
Thank you for having me. Thank you for the opportunity. Tears in children. Really, I was wondering if my presentation is 3 minutes or 6 minutes. I have no idea. Anyway, I prepared 2 cases just in case, because some of the information was 3 minutes, some other information was 6 minutes. So I present my first case. This is my first case. This is a baby, 2-year-old boy. He fell down and had previous vitreous surgery for vitreous hemorrhage, and he came to see me. He was referred to see me since parents were unhappy, and at the examination I found that he had giant retinal tear with severe PVR with fixed folds. You can see the fixed folds. You can see that, is that right?
Yeah. Yes, clear, doctor. Yeah, clear.
Okay. With fixed folds. You know, giant tears in children usually are associated with severe PVR, not like adults. In adults, there are cases with PVR, other cases are not with PVR, but in children, usually 100% of the cases, or let's say 95% of the cases, they have severe PVR. You can see the fixed folds here. Here, I start peeling posteriorly, and from posteriorly going anteriorly. Of course, in such cases, it's mandatory to remove the lens in order to prevent any anterior proliferation afterward. And this is, I use bimanual approach in such cases is very helpful. There are star folds even present at very anteriorly. And this is the importance of wide field viewing systems. And I peel and peel and peel until I feel comfortable about it. Here I injected dye, and once I realized that I removed the ILM without knowing it, because I was peeling posteriorly over the posterior pole, and you can see here how far anterior I go. And I'm not one of the advocates if there is stiff retina anterior, just cut it. I really take my time before deciding to cut the anterior retina. And even at the edge of giant retinal tear, I take my time before deciding. You see here, it's almost free, the giant retinal tear, without any PVR. And this is how the retina looked like here. At time of silicone oil removal, there was 1 surgery in between, and retina redetached in between. This is the time of final goal, having had the retina flattened, completely flattened at time of silicone oil removal. And this is the case. Patients are happy and parents are happy. This is my second case. This is I think 3-year-old boy, something like that. Suddenly they realized that he was not able to see with one eye, the parents, and they start looking where to go. And finally they arrived to see me. Here I injected Helon at the beginning, because if you inject heavy liquids will go underneath the retina and you can do nothing about it. In these cases, I use Helon to open whatsoever possible and to do the work. After peeling, I cut the nasal retina because there was intrinsic traction here, PFO, after removing the helon from inside the eye. You can see here, I'm just stretching the retina with my black flash in order to make it mobile, removing the ILM, and this is how the retina looked like at the end of the case. 3 weeks later, there was a recurrent of the retinal detachment, and you can see here, it's just inferiorly, there was traction, there was a recurrent of PVR inferiorly, and there was an open break inferiorly. I remove, usually I like to peel under silicone oil before removing the silicone oil. I think it helps me. I remove the silicone oil, do laser, and air exchange, and once again, I injected silicone oil. What about the other eye? The other eye, a month later, severe hypotony, giant retinal tear again. You see, the patient had already cataract. I had to do lensectomy. This is how the retina looks like. And of course, you cut the anterior flap of the giant retinal tear. And this is exactly the same picture of the other eye, of the giant retinal tear in the other eye, except this time the patient, he came earlier, since the parents, they knew about the previous eye pathology. And this is what I did. I did not cut, in this case, the nasal retina. I thought it was not necessary to cut it. And this is how the retina looks like. And in the case, currently, the patient has in both eyes silicone oil in both eyes, and the retina is flat. He has some vision. He goes to school, and screen sharing. Stop sharing. Yes.
Okay. Thank you, Dr.
Yes.
Faisal, for very nice and excellent technique as usual. So we have 2 minutes for discussion regarding the scleral buckling in joint retinal tear in children. Do you believe in it, or you support it, or no?
I believe in scleral buckle. I love scleral buckles, but I think in these cases there was no place for scleral buckle, since was the giant retinal tear almost for 360 degrees. And if it was not for 360 degrees, I made it 360 degrees, then there is no place for the buckle in such cases.
Yeah, I think because usually.
But I love scleral buckle. I like scleral buckle in PVR, not just in giant retinal tears, but in PVR as usual. Especially if you want to preserve the lens, it's always good to have
very
a
important.
support
Also,
of
the very important trick for this one. If you want to put a buckle, I think we don't want to be too much high indentation to avoid the slippage or the burst like the effect. So if you're going to use a buckle in a joint retinal tear, just mild to moderate indentation is enough. And also one more thing, as you see, in one of your cases, the recurrence is very high in this patient. So I think pre-operative counseling the patient, the family or parents about the incidence of recurrence of BVR, because in joint retinal tear, a lot of RPE migrate. It might cause membrane of the surface of the retina despite complete vitrectomy. So I think it's a good point to consent to the patient or instruct the family that we might need another surgery, and even if you have a successful one. So thank you again for your
Absolutely.
May I have one comment? Hello, Faisal. Thank you very much. These were excellent cases as usual. Let me just agree totally with my friend Dr. Fayyad. Whenever we have giant retinal tear more than 2 quadrants, there is no point in putting a scleral buckle. And the scleral buckle is, in these cases, is only to support the vitreous base. And as you said, we don't do a lot of indentation. It's only to support the vitreous base. The second thing that I wanted to say is always we have to think of laser treatment with the second eye in giant retinal tears, because usually it's a bilateral case. Thank you, Faisal. These were very interesting cases.
Thank you. I think for the sake of time, we also have to go for our next speaker, Dr. Hassan Al-Hasid. He is a VR surgeon at Dubai Hospital. He's going to talk about a case presentation about pediatric trauma. Dr. Hassan.
Assalamu alaikum. Hi.
Alaikum salam.
I want to thank Dr. Muhammad for invitation and Dr. Ahmed and Dr. Mudhi for moderate this session. I will talk about pediatric ocular trauma. Generally, pediatric ocular trauma is the leading cause for monocular blindness in children. Worldwide, around 250,000 of children complain from the serious ocular injury yearly. Around 8 per 100,000 of population per year.
Sorry to interrupt you, sir.
Yes,
Sorry to interrupt you, sir. Sir, you have not shared your screen, sir.
Can you share the screen, Dr. Hassan, please?
I share it. Pediatric ocular trauma, as we said, that the incidence around 8 per 100,000 per year. Around 30% of the ocular trauma in the emergency is related for the childhood. The pediatric ocular trauma is distinguished through the assessment and management. Especially, it will be difficulties during maneuver with the child, and the results in the myopia and affect the schooling and activities of the child during the daily and socioeconomic on the family and the child. And the most important thing in the pediatric ocular trauma is that it's preventable in most of 90% according to the studies. This case in our hospital, just the child has corneal laceration, traumatic cataract, iris damage, primary repair done. After that, the patient has corneal obesities and phakia, partial aniridia, vitreous hemorrhage with suspected impact of the posterior bole by the trauma. It was by knife. And the plan was for scleral fixation IOL with past plan vitrectomy for the vitreous hemorrhage and later for BKBs. This is the case for the child. We prepare first because there is no zonule in the temporal area. We prepare the flaps, and the most important thing in that flap here is just to keep it half of the sclera to avoid any ciliary body prolapse. And around 2 millimeters from the surgical limbus, it will be the entry of the absterno needle cortex. Here we take the help of the light to see the edge of the ciliary body, and you can see we use the marker and shaking hand for first we release the synechium, and to see we found that is in the nasal side there is a huge amount of capsule, but in the temporal side you can see there is scar where the damage was for the ciliary body. Even here, and there is some hemorrhage coming from the angle, and here we just enter by the absterno suture, Gore-Tex 0.8, and I use here it's the BMMA lens 7 millimeters, and just tie it through the eyelet of the lens, and after that deliver it to the anterior chamber, and I use the 3 to adjust the haptic and the 9 o'clock. Then I insert the other haptic in the sulcus, and you can see you can adjust the lens, and after that I use the locked slip knot to fix the lens, and then I embed this thread in the sclera to avoid any extortion of the of the needle. And after that, I wanted to make iris aeroplasty, but the problem is that this is just the visual axis for the posterior bole. And here you can find that, in spite, we suspected, but we don't know that it could be touched around the macular area. You can see there is touch. So in the prognosis in these cases, you can't expect it until you have a total visualization for this. Then indentation to see the periphery to avoid any retinal tear, because patient will go for the BKBs after that. And here's the end. And the DHA, we have through the 8 years, we have around 200 cases of open eye trauma. Around the pediatric cases was around 15%, and most of them in home trauma and during playing with sharp objects. The most common findings here is corneal laceration with cataract and iris prolapse. About the retinal cases, We have, from the beginning, 2 cases with retinal detachment with severe corneal opacity, and the patient mostly refer outside because of the family situation, and 1 case of endophthalmitis with eyelash and later developed retinal detachment, 1 vitreous case with scleral fixation which already presented, and 1 case for pars plana for posterior capsule opacity. I will not speak a lot about the classification, which already implemented in 1996 and is still active, and most of the work of us depend on this classification. About ocular trauma score, this is which we applied by Kuhn and depended to speak the prognosis for the family, and it's already implemented in the children. But there is another classification came in 2011. But according to the rest of the studies, the precise of the old or traditional one is more than pediatric, the BOTS. About the epidemiology and dietology, around the boys have 5 times more than the girls, and 50 of the cases happen on the home. Blunt trauma more than open ocular trauma. Sharp brainstorm is most commonly reported, and there is even by bites by dogs, toys, sports equipment. Closed globe injury has had favorable outcome as compared for the open globe rupture. Corneal laceration, most common findings, in spite of in USA's adnexal is injuries more than corneal laceration, and this is the difference between the mechanism of injury, the tool of the injury, the findings, different between different areas. And this is according to the study, you can find it that this difference is related for the environment. And about the improvement in the visual outcome, which happened through the last 20 years, this is related for the improvement in microsurgery and even in the rehabilitation of the visual through the intraocular lens and the treatment of the amblyopia. About how we prevent the pediatric ocular trauma, as this is preventable in 90%, so awareness of the environments around the children is very important, especially in the home, as this is according to the study in UK, and even in our small sample, we found that this is around most of the cases in the home. So the parents should be aware about the importance of supervision of the children during the playing, about the danger of the objects, and also the education for the school through the programs and the policies about how even provided to the healthcare staff in the schools to avoid any trauma for these children. And also about the education for the sport and the urgency of using of these eye spectacle wear to avoid any eye trauma. And also the regulation about using the safety devices. About the relation between pediatric ocular trauma and pandemic, according to the statistics, there is reduced in the number of the cases which come to the emergencies, maybe because of the pandemic, but also related for that about supervision of the children and the social distance, and which appear during the epidemic is that the increased exposure for the alcohol-based hand synthesizers during the 7-fold time more than before. And the last, and I will just share this about the surgical peers during dealing with this through the American Academy meeting last 2021, just about administer the IV antibiotics intravenous since the patient attending the emergency, and CT scan for all cases where you suspected maybe glass, especially with gas gun or air gun, if there is any eyeball from plastic, and use nylon sutures, not any absorbable suture for the sclera, and reposition of the uveal tissues, and also the urgency of the procedure. To conclude, education and awareness for all environment around the children is very important to prevent. Compulsory safety devices by law, urgent management without delay with the senior surgeons. Thank you. Thank you.
I think it was a perfect timing. Because of the paucity of time, we'll go to the next speaker. It is Dr. Mangad Dogra. He's a former professor and chairman of ophthalmology at Advanced Eye Center, PGI, Chandigarh, India. Presently, he is a director of retinal services at Grewal Eye Institute, Chandigarh. Sir has a significant contribution to the retina, especially in pediatric retina in India. Sir is going to talk about surgery in pediatric retina. Dr. Mangad Dogra.
Well, because of the paucity of time, the way I thought it is 3 minutes talk. So I have put very few slides and I took out the video. But you see, we must understand that the pediatric retinal surgery is different from the adult surgery, and there'll always be discrepancy in the anatomic and the functional outcome. And we have to explain beforehand the risk-benefit ratio to the parents and obtain an informed consent, because many a time, these are the babies where the prognosis may be so variable, and there'll be a lot of frustration otherwise among the parents. And you need an experienced anesthesiologist, especially for the infants, if you are doing like a surgery for premature babies. And I think you should not hesitate sometimes to do an examination under anesthesia, because then you plan it, you'll be in a much better shape rather than going straight away. Of course, amblyopia, we all know, is a concern before 6 years of age. Even if you have done a good job, you may have a problem. The current surgical approaches, of course, are the scleral buckling in children, in a small gauge lens pair vitrectomy, lensectomy, and vitrectomy. So most retinal detachments in children should be fixed with scleral buckle. I think I'm an old timer. I tend to do in most of the cases. That is my first choice. And of course, post-traumatic with retinal dialysis always only needs a buckle. You see, if you have a detachment with a trauma in a child like this, you can very easily fix it. But I'll go to extreme case here. I even had a video for this, but this is just a buckle, 14 years old. You see, everybody said, I'm going crazy here. Why I have to put a buckle? We need a major surgery here. But I could see the break and did a buckle. You see, even this all napkin kind of a ring went away. Retina settled. So you don't remove the lens. Otherwise, you would put oil, you do everything. And the gain was quite reasonable. So I think buckling in children should be the first choice, and that is what should be done. And lens sparing vitrectomy is a very exciting new thing, which mostly all of us, we love to do. Ideal for 4A, 4B ROP, which I do a lot, and vitreous hemorrhage, endophthalmitis, retinal detachment, also in some cases of fever. I'm not showing you the video, but a case like this, which came to us at presentation, was very bad, did laser, and very soon, in 2 weeks, became like this, 4B. You see, and you just go in, despite so much of vascularization, you can't even inject anything here because it will show a crunch. And you just remove the vitreous here, try to do as much as possible. This went back, and you can see here in 6 weeks' time, the retina is back. So I think lens sparing vitrectomy has a lot to offer, and we have to go in very early in cases like this. And lensectomy and vitrectomy would be required for cases which are complex, and they are not less. I think right in the first presentation, we have seen that in the child, how complicated the cases were with the giant retinal tear. And ROP stage 5 would need that. Many cases of familial exudative vitreoretinopathy and RD with coloboma. I think we're going to have a talk on that subsequently. And also sometimes what is called these days persistent primary, now called a fetal primary fetal vasculature. I had a very good video of this, and I took it out because I thought the time for me is very short. And this was a closed funnel RD in a 9-year-old male blind child. Other eye was enucleated during early childhood for this child. And this eye, you can see, is totally contracted retina. And after doing surgery, which I had a video I'm not showing, there was a giant retinal tear here, and the retina was like this. I could fix it with I put a band 240, as well as did the surgery with the help of a PFCL as well as removing a lot of membranes. And it could be fixed like this. It was still going down like that. And after, when I removed the oil subsequently at about 4 months, I think that could be easily removed and it became much better. And you see, child, despite having just a PL, could have a ambulatory vision. So that is what is important. And we should keep in mind that we might have to perform such a surgery sometimes. And so I would like to conclude here, since I took out the video, so I'm not showing that preoperative counseling is the most important. Talk everything. Otherwise, their expectation is unrealistic. And scleral buckling, as I showed you, even in one extreme case, try it as a first go. You will not lose anything. And it is something which should be done in most cases, I would say, if you can. And the small gauge lens sparing vitrectomy is most exciting innovation. I've been doing it a lot for the ROP 4A, 4B, and many of other pediatric retinal detachments. But lensectomy, vitrectomy, like in the last case I've shown, in complex cases, most challenging, which requires a long surgery, but may have a variable outcome, but still it is worth it, even if you can give a ambulatory vision to the child. It is said that even perception of light, I think they get a lot of positive sensation rather than otherwise they go into different mode all their life. So it's very, very important to perform even sometimes challenging surgeries like that. So thank you very much.
Thank you, Dr. Mangat. I think it was a fantastic presentation in looking at the paucity of the time we had. Doctor, I think the take-home message was very clear and loud. It was saying that the scleral buckle has a role in a pediatric retinal detachment. Give a try as first option. And if it is not working, probably you can take up later for a vitreous surgery. And also you showed some good cases of vitrectomy, lens sparing vitrectomy and lensectomy vitrectomy for ROP cases. This was fantastic. To talk more about the scleral buckle in pediatric cases, I think we have Dr. Abdul Salam here. He wants to go ahead before Dr. Vishali Gupta. He has some other clinical, engagements later on.
Well, thank you so much. I'm in the operating room, and I really appreciate the kindness of Dr. Gupta to get me to go before her. And thank you so much. I'm very glad to be here. Give me just 1 second. I'll share my screen.
Yes.
Okay. So I think in short, really, what do I do with scleral buckle? So in children, this is what I do in general. If there's a detachment without PVD, which I call non-PVD retinal detachment, then I would buckle that. It's very easy to sort out, and these are usually the detachment in children. I also use buckle in case that there's shortening of the retina, but it's not enough to do a retinectomy. That's my main use of buckle. So the question is, okay, what's this detachment? That's a horseshoe tear detachment. We know that there's PVD. That's the type of detachment we get in adult. Well, this is a small detachment with one break. If you want to buckle, that's very good. If you want to do PPV or pneumatic, that's up to you. But I just want you to recognize this category, which we see more in adult detachment. In children, it's different. This is the detachment we see in children. It usually atrophic hole detachments or holes with myopia. And there's no PVD. And it's very important to recognize that there's no PVD here. And for me, when I see that, I just do buckle on them. That's the other type of detachment you see in children, which is a dialysis. And again, it's really the best thing is to do a buckle on these patients. And I'll tell you the reason why. We all know the vitreous is very adherent. It's very difficult to separate the vitreous in children. And in some patients, especially high myopes, they have lattice peripheral. And if you try to separate, you end up creating lots and lots of breaks and becomes a very difficult surgery where it's a slam dunk with a buckle. So I'll just show you some cases quickly, keeping to the time. So lots and lots of buckles here, but the ones I tend to use, I like to use the very small one, the 5mm or the 4mm. This is here a boy, he's a teenager with a dialysis. And what I've done in this patient is we've put the segmental buckle, we did external drainage, and interestingly, we found that we forgot to do the cryo. So, but he was really dry, and then we did laser on the operating room. But I just want to tell you something as well. Cryo actually is not important in the first operative period. What's important is the buccal-tear relationship. But the main reason for the cryo is as the buccal effect goes away, you want to have a permanent adhesion. So if the cryo is not working, or if you forget to do it, like what we did, just leave it and you can come back in a month and laser. Just something interesting just to be aware of. So that's a case here. Then how do we do it? I mean, we try to do like the minimally required exposure. So we just expose the muscle. If you're starting, maybe do more muscle exposure. Then we mark the break. And with segmental circumferential, it's very easy. All what you want to know is where, which quadrant the tear is. And usually you end up the anterior suture near the muscle insertion and the posterior suture about 1.5 times the width of the buccal back. Okay. This is a young man here who history of ROP, never required surgery, had a detachment, and we put a circumferential buccal. So no Pvd detachment. I totally reinforce the message that was said in the previous lecture. Definitely for that one, a buccal. Here, this is a case with a young man, 16-year-old, actually with PVR detachment and retinal shortening and multiple breaks. So in this case, again, similar to what was done really in the previous lecture, is just in this one, I would do an encirclement, lots and lots of breaks, and there's PVR. So an encirclement and drainage. And he settled very nicely. It was a 42 and 70 band. And then here, my last case, and as you would expect here, the band goes 4 millimeter behind the muscle insertion around the equator area. You can also modify that, depends when the breaks are, but that's usually covers the breaks very well. And we do loops, but you can do sutures, and both of them work so well. This is my last case, and I just want to highlight here a point. Sometimes we have that in dialysis, where actually the retina is very far off the choroid, and there's actually some sort of a slippage. These cases, they may not work with buccal. You can try, but in your mind, know that actually it may not settle with buccal. It just, you cannot really account for that slippage or for that really like inward rolling of the retina when it's very far away from the choroid. And that's what we did in this patient. We did a buccal, but it did not work. And we did drainage and it really did not work. It just remained high up. And then we came and we did a vitrectomy. And now I want to show you why not to do a vitrectomy in children. And that's actually his 21-year-old. But look what happens. The retina is detached and then the hyaloid is attached. And it's really very difficult surgery. Then here you're working on that hyaloid with the retinal detachment and there's no counter traction and it's just really difficult surgery. And there are lots of things you can do. We find the pick very helpful if you cannot get it with the cutter. You can also support the eye with PFCL and induce the hyaloid, but you've made a very simple buccal surgery to a very difficult surgery. You can also do a drainage retinotomy and then flatten the retina and then try the hyaloid separation. But usually it's a mix of all these until you're able to get the hyaloid. So my advice in the no Pvd detachment really is a scleral buccal. And it took us a while in this patient to be able to get the hyaloid off. And then we managed to get it off and then lasered. And then he ended up with flat retina. But I think the message, I totally reinforce the message, children detachment equals scleral buccal. Thank you so much.
Thank you, Dr. Abdul Salam. I think it was one of the best presentations. Well, in children, the success rates are quite high with scleral buccal as discussed, especially with the 1 or 2 quadrants detachment with the 1 or 2 retinal breaks. Probably the success rates go down if there are multiple breaks and 3 to 4 quadrant detachment or associated with Stickler syndrome or any vitreoretinal pathologies or in some cases, we don't see a break either in pre-op or under GA. In those cases, probably the missed break can have a recurrences. This is my experience. So I would always give a choice of scleral buckle because there is no sequel, there is no tamponade and no sequel of cataract, glaucoma, or any such things. And the second thing is about, I would most often use segmental buckle if it is 1 or 2 quadrant, and you encirclage with a 240 band. Would you do it in all cases? And I most often use a explant.
I have one question to you. Could you have tried putting a gas bubble in that case where the dialysis was hanging up? Because many cases we inject a gas bubble and give a position, it goes back, and then maybe we could avoid the vitrectomy in some of
Actually, that's a good idea. It was inferior. We did not try, but that was a good idea. I think what really made us not try because it was inferior. And then we did not remove vitrectomy at that time. And if I just can add something quickly, I think what Dr. Rao mentioned, even if you don't find a breaks, putting a band and drainage usually sorts out the retina. So I think in children, I mean, we're all saying the same message, try buckle as much as you can. And I'll put, when I finish, I'll put in a link of my YouTube channels, and it has the technique of how to do buckles for the young generations, just for the sake of time.
Thank you very much, Dr. Abdul Salam.
Thank you so much. And thank you, Dr. Gupta, again.
The next speaker is Dr. Vishali Gupta. I think most of us would know in this part of the world, since she had a stint at King Khalid Eye Specialty Hospital. Ma'am is a professor at PGI Chandigarh, India. She is not just managing retina, she is also a well-known UVA consultant. Ma'am is going to talk about the management of retinal detachment in choroidal coloboma. She's going to talk about surgical tips.
Thank you. Thank you, Dr. Rao, for a very kind introduction.
Thank you.
And it's always a pleasure to be part of all meetings. It's like a second home. So my talk is very simple, and it's about managing retinal detachments in retinochoroidal coloboma. Now, whenever we look at the coloboma and associated detachments, the first thing is obviously to look what type of coloboma is it, disc involving, not involving, and you have to kind of categorize into its type. Once that is done, I think the most important step, which all the previous speakers have been highlighting, is to identify the break. Simply because there is a coloboma does not always mean the detachment would be because of the coloboma, because these patients might have a peripheral break. And looking at the configuration of the RD, you will be able to know whether the RD is from the peripheral break or from the coloboma, because coloboma might have breaks in locus minoris resistences or in the intercalary membrane. Now, if you know there is a peripheral break, this might be a subset of patients where scleral buckle in these children may be really helpful. But the key lies in the meticulous indirect ophthalmoscope examination, which somehow our younger generation is kind of, losing that art. The second important step is, because majority of the time we do go in, is the Pvd induction. You have to be firm but gentle to avoid iatrogenic trauma, as the vitreous is very adherent, very quick. The retina, thirdly, is very mobile, so there is a risk of iatrogenic break. So don't go very high on vacuum while creating induction, and then is while doing fluid gas exchange. Now, many a times, especially in the beginning, you actually may not be able to identify the break, which is right at the locus minoris. But when you are doing detachment, and I'm going to show these steps, when you are going the fluid gas exchange, the fluid becomes bullous. You may have to find where it is draining, but in case it's not draining, you may have to create retinotomy. And finally, lasering the edges, which is one of the important steps. Now with this, I'm going to show a video, which is edited video, just to highlight the steps that I have been mentioning. Identifying the vitreous, as I said, the retina is mobile. So the moment you are trying to induce PVD, you are trying to separate, you have to be very gentle because the retina is going to jump into your cutter, and the coloboma, which is very wide, you don't want to put PFCL at this point. But if you have patience, you can. Now, you know, you have removed the vitreous, but make sure that there is no vitreous. So even if you have to repeat Kenacort or stain it with the blue dye, if you are using brilliant blue or whatever, make sure that all the membranes are removed, because many a time these patients might have layer after layer. And not only the cutter, you may have to use forceps. For example, this is the same area where we had removed the vitreous, but when we put Kenacort back again, you realize there were still membranes which need to be taken out. So this is very important, that the vitreous needs much more meticulous attention. Then the third step that I was telling you, that sometimes you may not be able to identify the breaks because they may be, if they are in the intercalary membrane, you will quickly see them, but they may be hidden somewhere in the locus minoris. So people have used dye, and I have also, you know, I have even tried microscope integrated OCT to look for that break, but believe me, nothing works. More works is the patience. Just put your fluid needle where the fluid is getting bullous, where it is getting, have some patience. And if it drains, it means your break was in the edge, which you probably sometimes may not be able to. Now here is the break from where the fluid actually drained. Once the fluid is completely drained, then comes the next question, that is the laser. Now, if you have this coloboma, which is passing through the edge of the fovea, the consensus is that you should treat the fovea. But to be very honest with you, personally, I cannot put burn over the fovea somehow. You know, I have this mental block. So if it is a first surgery, I do a good laser. But I generally, if the fovea is not involved, I would just avoid lasering the fovea. But the recommendation is fovea should be lasered. And of course, the complete works, and that you have to complete it. And surgery, depending on the tamponade, I'm sorry, this is. And this is the post-op. As you can see, I've still spared the fovea. It's a controversy. If you want to go ahead, put good layer of lasers around it. But these were just some of the brief tips that I wanted to share with you all. Thank you very much for the very kind invite once again.
Fantastic presentation, ma'am. You spoke about the type of coloboma, the peripheral break versus the intercalary break. Ma'am, I just wanted to know, you also spoke about the break, how to identify a break with a fluid air exchange. My question is, can we identify using a dye? You spoke about it in a briefly.
Yes. Personally, I haven't used, but people have reported putting the dye in the subretinal space and seeing it through the intercalary membrane from where it is coming. I haven't honestly done that because I find it very messy, but I have tried putting the microscope integrated OCT along the edge, trying to find it doesn't work. To be very honest with you, it's just from your experience, you know that break is somewhere there. You know what I mean? I mean, you just—
Absolutely fine, ma'am. The second question is, I mean, most often when you take the fluid needle, you know that it is bulle and it is draining somewhere. Is there a chance that it can create a gush of fluid through us because it's atropic at the edges or a very thin retina? You can create a break with the bullous
I think the trick is that when you are introducing the needle, go it from the side of the coloboma, because your retina is kind of at the edge. So if you direct it from the coloboma towards the retina, the break is going to be there, and there is going to be gentle egress of the fluid. Rather than going it on top of the bulla and trying to locate the break, then you're going to create a hole anyways.
The next question is,
No, just thank you, Dr. Dr. Very nice video. Just I want to highlight something you showed very nicely in your case, that you have to restain the vitreous with the skin cord or trials, because sometimes this patient will have vitreous crisis, so the vitreous is layered. So you might think that you remove the vitreous, and you despite that you find that it's not removed. So the idea of restaining is very nice in those cases. Also lasering the edge of the coloboma also is very nice. So I think it's a difficult, challenging case. Well done. And I think now we should move to the last speaker, Dr. Ayman Madanat. He is a senior consultant and retina specialist in Amman Eye Center. Dr. Ayman is going to talk about the macular buckling in children. Dr. Ayman, please.
Thank you, Dr. Ahmed. Thank you, Dr. Madhab, for the nice presentation and for the invitation. It's really a pleasure to be part of this excellent session with our esteemed guests. I can share my screen. Idiopathic macular pucker in children and young adults. This is my case. It's about 16-year-old female patient. She presented to our center 4 years ago with progressive loss of vision in her left eye noticed for more than 1 year. The vision, in fact, was 0.1 in her left eye. It was 1 in the right eye. The anterior segment was completely clear, normal, with no signs of inflammation, and the lens was also clear. The intraocular pressure was normal in both eyes. Now, examination of the posterior segment showed that there was no signs of inflammation, namely intermediate uveitis, choroiditis, or any retinitis, no history of any systemic disease, and the patient was quite healthy. Now, the epiretinal membrane was well defined and fibrous in appearance, in contrast to the cellophane appearance that's typical of epiretinal membrane in elderly patients. There was macular dystopia present, which is more common usually in juvenile pucker than in the adult type of pucker, and the rest of the retina was completely normal. PPV with peeling of epiretinal membrane were performed. And in fact, I want just to reiterate one thing that was mentioned, that in this patient there was vitreous cases, and when we removed the first layer of vitreous, there was another layer on the retina that has to be removed. Island peeling was also done because of the higher rate of recurrence in these cases, and to ensure that we did remove all the contractile tissue from the surface of the retina, although we don't do it routinely in elderly patients with macular pucker. The removed tissue was sent for histopathology. This is the case. As you see, it's very fibrous, white fibrous tissue. This is towards the end of the peeling. See, it's very adherent. It has to be cut near the optic disc by a scissors, and the specimen was sent for histopathology. As I said, I don't routinely do island peeling in macular pucker cases, but in this case, I did an extensive island peeling just to prevent recurrence. I made sure that I did remove all the contractile tissue from the surface of the retina. Postoperatively, the patient was followed up for 3 months. Then she was lost for follow-up. In fact, she was not from Jordan, and I think she left and she never came back. Unfortunately, the visual acuity did not improve much during this period. It was 0.1. It improved to only 0.2. Although, as we know, patients with epiretinal membrane postoperatively, they may take up to 1 year to improve. Now, histopathologically, the histopathology report showed myeloblasts, differentiation of retinal pigment epithelial cells, and fibrous astrocytes. Now, idiopathic epiretinal membrane, as you know, in young patients is extremely rare. The new collagen formation are more common than in idiopathic epiretinal membrane in older patients. The clinical and structural features of juvenile epiretinal membrane reflect more rapidly changing contractile tissue compared to the more quiescent features in the epiretinal membrane of elderly patients. Some of our colleagues, retinal colleagues, they go up to considered congenital. Juvenile epiretinal membrane are usually white and opaque and have an extrafoveal epicenter. In rare cases, they may be associated with combined hamartoma of the retina and retinal pigment epithelium. Usually requires early surgical intervention compared with epiretinal membrane in elderly, where epiretinal membranes are more quiescent in most of the cases. Thank you very much.
Thank you, Dr. Ayman. It was a nice and quick presentation. Yes, I think for macular buckling in the children, as you mentioned, it's quite different from the adults in terms of the connectivity and the adherence to the retina. And I believe that the timing, you can, wait a bit for the adult side, but for, children, I think you have to interfere early. As you show in your case, the retina takes a long time to return back to normal contour. So I think during the difference in nature, you need to interfere early. And also, I think all of us agree that we should peel the ILM in those cases, or if anyone does not peel the ILM in those cases.
I want to hear the opinions of my colleagues, Dr. Dogra and
as
Dr.
far as
Doctor.
I'm concerned,
do you peel ILM?
I don't peel ILM. Yes.
You don't
macular buckling.
Peel ILM because yes, in macular buckling, because I have seen thinning of retina, and recently there has been report that there is a ganglion cell layer loss, and I have myself documented that that retina becomes much thinner. I think it has to do something, of course, not with the anatomical, but the functional outcome in the long run. That is my take on this.
I think you might be right, because I don't peel the ILM, as I said, in all my macular pucker cases. But in this particular case, I thought with the retinoschi, with the vitreous cases, I have to remove the vitreous twice. I thought that there might be some contractile element left on the macular area. So this is probably why I did remove the ILM in this case. But I think you have a point of view.
Dr.
Yes,
Dogra,
Dr.
what is the percentage of recurrence if you don't peel the ILM in such cases?
Very low, very low. I have done so many cases, maybe just about, it is less than 10%. And you can always go back in case you need to do it. Because I think ILM peeling also, we are overdoing. And that is where we don't look at the vision. There is the problem. This is also happening with diabetic macular edema eyes. More we peel, the worst outcome we get. That is also happening.
I totally agree.
I think it's a debatable point, and we didn't forget that the ILM, the food plate of molar cells, so they have some physiology. So if you can preserve it, better to preserve it, and you have to remove it. Okay.
Let me stress one point, Ahmed, that Dr. Dogra has said. The recurrence rate in these cases is not common, but definitely it's commoner than in adults. But you see more recurrence in the pediatric age group more than in adults, but in general, it's not common.
If there is a recurrence, then I would peel.
So you would peel if there is a recurrence of the case. Yeah, it's a good point, definitely. But the other point that made me also decide to peel is the macular dystopia.
Yeah, that's true.
You've seen that there was a macular dystopia, and I was a bit concerned about this. I thought, well, because of this also, ILM peeling might be a good choice.
And sometimes you're just tempted to peel.
Maybe as a retinal surgeons, we love to peel, but definitely I hate peeling ILM in every case. I know that it's protective for the retina.
Yeah, I agree. So thank you so much. I think we end our session just to highlight the take-home message from this session is the pediatric retina, the term of surgical is different from adults, as all the speakers show that. Starting from the pre-operatively, I mean the most important thing here to consent the parent family, the prognosis in terms of recurrence, also the technique during the surgery. We have some challenging and detaching the posterior hyaloid, and also the tip and the fix that's mentioned by Dr. Gupta also for the choroidectomy and the scleral buckling still have a rule there. So I think all this matches. I hope it was clear. And one more question for all of you: in case if you try to peel or to detach the posterior hyaloid and you don't manage to do it, what do? If you try everything, big high vacuum, and you still cannot detach the posterior hyaloid, how do you do in those cases? Anyone can answer because you have just 1 minute.
What I do is, if I use mostly in such a situation, put in a oil and come back.
Exactly.
And it is very easy. It matures
Yeah.
underneath and you remove it. I have done
Thank
it in
you.
children where I
Yes.
failed to, despite my best effort. In
Exactly.
very short time, you will have very nice.
I have a
mature,
very nice, yeah.
and you remove it nicely.
Yeah. So thank you so much. And also,
My hands, I mean, what you cannot induce with a high vacuum, probably you can do it with flex loop. I think it's a real big boon to induce it in cases of
using the high vacuum, you have to be careful, especially in have Marfan syndrome or Stickler syndrome, because the abnormal vitreoretinal adhesion. If you use high vacuum at the disc, try to detach it, you might do a digenic break most commonly. So the best way, I think, to visualize it, to try Epsilon, try with venous loop or PIC or something mechanically rather than using high vacuum. And if you didn't manage it, as Dr. Dogra said, thank you, you can put some silicone and come back again. You would definitely find a plane to go. So
I would say, Ahmed,
Okay.
I would say, Ahmed, just patience. You know,
Yeah.
you have to be patient. Believe me.
Exactly.
In most of the cases, it works out.
Yes.
I've been with cases where I peeled the hyaloid from the posterior pool, but I could not remove it up to the periphery. I used to stop. I used to stop at that point. But be patient. You will be able to remove the hyaloid from the posterior pool in most of the cases.
Okay, thank you so much. I would like to thank all the eminent speakers and Dr. Rao for sharing with me this session. It was very a good talks, and hope to see you again, and take care, stay safe, and Assalamu alaikum. Take care. Bye bye.
Thank you, Dr. Ahmed. Thank you, Dr. Medaf.
Thank you.
Thank you.
Thank you so much. Bye bye.
Bye bye.
Thank you.